Welcome everyone to Medical Management of Advanced CKD Without Dialysis with Dr. Susan Wong. I'm Peyton Smith, Coordinator for the Coalition for Supportive Care of Kidney Patients. Before we begin, just a few housekeeping items. For clearer reception, attendee lines have been muted. We encourage questions throughout the webinar and ask that you use the chat feature on the right side of your screen to submit questions. When submitting a question via chat, first type your comments and questions in the text box. Second, choose all participants. And then third, press enter. We will attempt to answer all questions during the presentation, as we may not have time for questions at the end of today's presentation. At the end of the webinar, as you close your webinar screen, you should receive a pop-up evaluation. We greatly value your feedback. And finally, all webinars are recorded and will be posted to the Coalition's website at kidneysupportivecare.org within a few weeks. Dr. Samantha Gilfan will be serving as our moderator today. Dr. Gilfan obtained her medical degree from Mount Sinai School of Medicine with distinction in medical education. She went on to complete residency and chief residency in internal medicine at Yale New Haven Hospital. She pursued a nephrology fellowship at the University of Pennsylvania, and then a hospice and palliative medicine fellowship at Harvard. She has recently accepted a joint faculty position in palliative care and nephrology at Dana-Farber, Brigham and Women's Hospital. Her interests include conservative management, moral distress, and pain management in patients with kidney disease. I'm going to turn it over to Dr. Gilfan now.
Thank you, Peyton. And thank you so much for everyone who's tuning in today. I'm very excited to get to introduce Dr. Wong and to hear her talk. I'm also delighted that this is basically the only event that hasn't been canceled this week, so I'm glad we can still convene in this format. Dr. Wong's an incredible leader in this field and a great source of expertise and research in this area. So, formally introduce her, she is an assistant professor of medicine in the Division of Nephrology at the University of Washington, an investigator at the Kidney Research Institute, and a nephrologist and core investigator at the VA Health Services Research and Development Center at the VA Puget Sound Healthcare System in Seattle, Washington. Dr. Wong leads a patient-oriented health services research program on treatment practices and end-of-life care for patients with advanced kidney disease. Her goal is to create more patient-centered models of care for patients living with kidney disease. So we're really so excited to have you here, and I have you take it away, Dr. Wong.
Can everyone hear me?
Yes.
Oh, great. Well, thank you so much, everyone, for joining this webinar, given the state of our country right now. So thank you so much. Before I begin, here we go. Before I begin, I do have a couple of disclosures. That all said, I don't have any conflicts of interest. Today I wanted to start off by taking a step back and talking about the epidemiology of medical management, that is, who's choosing this treatment pathway and why. And then I'm going to move into some of the evidence for why this is a reasonable option for many of our patients. I'm then going to discuss some of the emerging approaches, clinical approaches to medical management. And then I'm going to end with some thoughts on the challenges of doing research in this area as we try to move the field forward. So about its epidemiology, well, I think it's fairly widely recognized at this point that not all of our patients will choose to undergo dialysis. Medical management is still relatively uncommon in this country. In the National VA healthcare system where I practice, about 1 in every 7 patients who reach the advanced stages of kidney disease or a GFR less than 15 will forego initiation of dialysis. This is a study where we looked at the distribution of patients with a GFR less than 15 based on their decisions about treatment of their kidney disease and stratified by age group. Here, what you see in the blue bars are patients who went on to receive dialysis. The green represents those who were preparing for dialysis but never started dialysis, or the opportunity never arose before they died. And the orange reflects those in whom there was a decision against dialysis. And what you can see as you move from the right to the left is that the decision against dialysis is more common in older ages, such that when you get to patients over the age of 85, about 44% will forego dialysis. So even though treatment rates for dialysis decreases with age, treatment rates are still very high in this country as compared to other developed countries. In the same study, we plotted treatment rates in the national VA healthcare system against treatment rates reported in other developed countries such as Canada, Australia, and New Zealand. The blue is our health system, the dark blue is our health system, the light blue is Canada, and the white is Australia and New Zealand. And what you can see is that for younger patients, we almost universally dialyze them. But once you get to patients over the age of 75, there's a real divergence in practice, such that when you get to patients over the age of 85, we're dialyzing about 41% of these patients as compared to around 4 to 7% in these other countries. And so we speculate that not only are decisions to forgo dialysis less common in this country as compared to other developed countries, but it's also probably less common in the private sector as compared to the public sector, like the VA. So this is a study that looked at the likelihood of veterans who are dually eligible to get their care in the VA or in Medicare, which is a fee-for-service system, to see what their likelihood was of starting dialysis. And veterans who get most of their care in Medicare or fee-for-service system were far more likely to be started on dialysis than if they got their care from the public sector of the VA. And this was particularly true among patients in whom we're most nervous about when they start dialysis. So patients over the age of 80, those with dementia, and those with metastatic cancer. So looking at factors at the patient level, we found that in our work in the National VA Health System, patients who opt for medical management not only tend to be older, but they also tend to have a higher burden of comorbidity, such as heart failure, cancer, and dementia, and they receive less nephrology care than those who end up pursuing dialysis. When we look at medically managed cohorts from around the world, we're also learning that patients who opt for medical management tend to have a slower rate of kidney decline. They tend to live alone. They tend to have poor functional status. I think interestingly, despite having a greater burden of comorbidity and poor functional status, they report similar self-perceived quality of life as those who receive dialysis. We also know that patients who opt for medical management are more likely to have completed an advance directive. From qualitative work, we're also learning about the values and healthcare goals of patients who opt for medical management. And there have been multiple qualitative studies now interviewing patients about what shaped their decisions about treatment of their kidney disease. And for interviews that included patients who were already on dialysis or were planning to start dialysis, what they indicated were their concerns and considerations and shaping their decisions seem to revolve around longevity, concerns about burdens on family and friends, ability to maintain their current lifestyle and social roles, financial considerations, and quality of life. But when you look at the qualitative results from qualitative studies of patients who are enrolled in medical management programs, what they indicate is that their concerns and considerations in what shaped their treatment decisions are really quite different from those who went on to receive dialysis. Patients who are enrolled in these medical management programs spoke of a desire to be relieved from pain and suffering. They placed importance on the non-physical domains of well-being, like spirituality, psychology, and existentialism. They also placed importance on independence and not being abandoned by their providers for the decisions that they make. They placed importance on learning how to adapt to prognostic uncertainty, and they sought a dignified closure to their life. So why might medical management be less common in this country? May not only be due to health system and cultural differences, but also in this country, patients who opt for medical management receive much less support for their decision than if they had simply chosen to go on to dialysis. And this lack of support comes across in different ways. So if you look to our professional societies and our clinical practice guidelines, you're not going to find anything really helpful on medical management except this one honorable mention in our clinical practice guidelines, which really reads more like an afterthought. It says, although logistically hemodialysis is easiest to implement, PD and conservative care are important options too. Our biases also can be more implicit. Take, for example, some of the patient educational materials that are available on medical management and dialysis. So what you see here is the cover of a magazine featuring an article on dialysis, and it reads, "Don't let dialysis stop you." And there's an image of a young woman who has summited a mountain. It's positive, it's inspirational, it frames dialysis in a positive light. And then look at the couple of patient educational materials that are out there on medical management. I show you one handout from the National Kidney Foundation called If You Choose Not to Start Dialysis Treatment. And what you see is an older couple. One is in a hospital gown. One gets the impression that he may be ill. And in my personal view, I think this couple looks kind of anxious. If you look at the NIDDK website of medical management, what you see is a close-up shot of an elderly man's hands, and he's lying in bed, presumably ill. And while, if this is my personal opinion, while these images are very calming, I also think they're kind of depressing. Our biases also come through in the terms that we use to describe medical management. So I actually call this approach to care conservative care, but I realize, and I do that because that's what our clinical practice guidelines refer to this kind of treatment approach. But I recognize that the coalition, as well as other members of our community, and in practice use different terms, and there's a lot of different kinds of terms that are out there to describe this treatment option. Some of the terms are more positive than others, and then others are downright scary. So I attend on the wards, and one time I was in a room with a trainee and with a patient who had chosen not to do dialysis, and she said to him, "By not doing dialysis, you're choosing to go home and die." And that landed so painfully for the patient that he got so upset he left AMA after that. Interestingly, he's actually still alive, 4 years later, but still, this is the kind of language that people are using to talk to their patients. Beyond these implicit and explicit biases, patients who opt for medical management also face ostensible barriers. So this is a qualitative study that we did of 850 patients in whom there was a decision to forego dialysis, where we analyzed their medical records to understand how this decision unfolded. And in our reading of provider chart notes, we found that when patients expressed a desire not to undergo dialysis, providers' reactions could be classified in 4 ways. 1, when patients were refusing dialysis, providers responded by repeatedly questioning patients' preferences. As this nephrologist documented, repeatedly every time asked, says he will never agree to dialysis and will die first. He gets angry, belligerent when asked this question, and says it's his right to refuse any care he chooses. Second, when patients were refusing dialysis, providers responded by questioning patients' competency to make this decision. So this hospitalist wrote, "He has expressed his wish not to receive dialysis for a long time. He has several personal circumstances that may incite depression and refusal of treatment. Will request psych consult." Third, when patients were refusing dialysis, providers responded by simply trying to change patients' minds. So this social worker wrote, "Had numerous family meetings with patient and his family in an attempt to convince patient to accept dialysis, but patient has always stated without fail that he did not want dialysis." And lastly, when patients were refusing dialysis, providers responded by proceeding as if patients would change their mind. And so this primary care provider wrote, "Adamantly and clearly refusing dialysis, even to consider it. My concern is that this may change as he begins to feel unwell." And so rather than find ways to proactively support patients' wishes to forego dialysis, we resist, we delay, and because we try and fit patients into a pre-dialysis pathway. When patients do have clinicians who accept their preferences, and it can still be a difficult path, not just for the patients, but also the providers who want to support their patients opting for medical management. So this was another qualitative study that we did of a national sample of U.S. nephrologists who have been proactive in supporting patients who opt for medical management about their experiences and approaches to caring for these patients. And the nephrologists in the study described several common challenges to medical management. First, when patients were opting for medical management, nephrologists described needing to carve out a scope of care within existing systems that were not optimally configured to support their patients' needs, such as this nephrologist said. He initially saw me in my kidney clinic and then transitioned over to my palliative care clinic, more for practical purposes because I can do home-based palliative care there. Second, when patients were opting for medical management, nephrologists described finding it difficult, described a need to be creative in filling care gaps for patients. So this nephrologist said, I give patients my card, it has my cell phone and my home phone on it. I tell them they can call. The mechanics of doing the best I can are difficult, but doing the best I know how. Third, when patients were opting for medical management, nephrologists found it difficult to ensure that their patients' wishes would be honored when they interface with the rest of the healthcare system. So this nephrologist said, patient was old and fragile and quite explicit in her desire not to do dialysis. Then she had gone down to visit other kids in a different city, and they had gotten worried about her and dragged her off to the ED. They put her on dialysis without discussing it with her. And finally, when patients were opting for medical management, nephrologists described having colleagues who sometimes made them feel that they were practicing outside of local norms. So this nephrologist said, I have another patient who's 89 who never wanted dialysis, and she was actually a really functional 89. Some of my colleagues were like, really? You're not dialyzing her? A lot of it is done jokingly. That never feels good. Other studies have also looked at some of the barriers to providing medical management. At the system level, these barriers have included lack of clinical practice guidelines on medical management, lack of training and education and research in medical management to guide practice. Not only are there financial incentives to start dialysis, but there are also strong cultural norms favoring the use of technologies like dialysis. It's an attitude of, if we have the luxury of such technologies, shouldn't we be using them? At the provider level, there can be deep moral distress about not doing everything to prolong life. There are provider fears of failure and inadequacy, and fears of taking away hope if they don't provide dialysis. There's also this notion of practice inertia, or it's generally hard to change the way we do things if we've gotten comfortable with a routine. And so collectively, I think all of these findings demonstrate how much more work needs to be done to build a cultural and clinical infrastructure to support patients who want medical management. Now, even though medical management is the harder path chosen, I do want to emphasize that it can still be a very rewarding one. So this is a survey study measuring patient satisfaction with the decision-making process for treatment of their advanced kidney disease. Experiences were rated from 0 to 10, 10 being the most satisfying, here indicated in the blue. And as compared to patients treated with dialysis, patients who had opted for medical management reported higher levels of satisfaction with their treatment choice and the process of shared decision-making. Right. So now moving forward, I wanted to talk a little bit about the clinical outcomes and evidence for medical management. So while in most circumstances, dialysis affords greater survival, it comes at the expense of greater interaction with the healthcare system. So this is a meta-analysis that confirmed what I think many of us already intuitively know. So given the available data, this meta-analysis included three studies. These studies included patients over the age of 65. Survival was anchored at a GFR less than 15, and multivariate analysis included age and some comorbidities. And they found in pooled estimates that dialysis does indeed afford greater survival than medical management. The thing is that with the survival advantage of dialysis, there comes important trade-offs. So this is a study comparing healthcare utilization between patients who opt for dialysis, indicated in the blue bars, and those who opt for conservative care, indicated in the orange bars. And what you can see is that patients who receive dialysis have more outpatient visits and spend more time in the hospital than those who opt for medical management. This is a study we did in the VA comparing end-of-life care between patients who received dialysis and those who had decided against receiving dialysis. Blue, again, is those who got dialysis. Orange is those in whom there was a decision against dialysis. And what you can see is that patients who opt for medical management receive less intensive care near the end of life. They're less often hospitalized and less often receive an intensive procedure. And they more often receive supportive care services near the end of life, like palliative care and hospice services. So while in general terms, there are differences in outcomes between patients who opt for dialysis and those who opt for medical management, when you look specifically at those who are older and have a high burden of comorbidity, survival and quality of life may be similar between these two groups. So I'm not going to get into the particulars of these studies, but just wanted to mention that there have now been 8 studies published that have shown that median survival between those opting for conservative care and those opting for dialysis are similar. And this is one of several studies published comparing symptom burden between patients treated with dialysis and those treated with medical management. This one comes from a renal supportive care unit in Hong Kong. The table is composed of actually 2 parts. On the left, you see the prevalence of putative symptoms of uremia. On the right, the severity of these symptoms scaled from 1 to 6, 6 being the worst. And what you can see is that symptom burden is actually quite similar between both groups. And it suggests that we can do as good a job in treating the symptoms of uremia with palliative care and medicines as we can with dialysis. And this is one of several studies comparing quality of life trajectories between patients opting for medical management and those opting for dialysis. Here I show you several box plots. The orange indicates patients opting for medical management or in the study conservative care, and blue is those who are opting for dialysis. Those who are opted for dialysis, their scores were split up into 2 phases, the pre-dialysis phase and the post-dialysis phase. And what you can see is that with patients with medical management, they have a pretty stable trajectory. They have a pretty stable trajectory in their mental health scores. In the dialysis group, there's a lot of variability during the pre-dialysis phase. Their scores are very erratic and then stabilize with starting dialysis. Similar patterns can be seen with physical health scores in patients managed conservatively and those who opted for dialysis. Okay. So while these studies show very promising results regarding medical management, I still think it's important that we maintain a critical eye on the evidence and be cautious when making inferences. I think it's important to point out that the data on clinical outcomes with medical management is almost all based on observational data. This makes sense because methodologically it's unethical to do a clinical trial, a randomized clinical trial, and between dialysis and medical management. But that said, there is likely confounding that explains some of the difference or some of the lack of difference between medical management and dialysis. Second, most of the evidence for medical management originate from other countries, and it's not clear whether or not those results are really relevant to our population. And then third, treatment decisions for advanced kidney disease are far more complex than just picking medical management or picking dialysis. There are many patients who are ambivalent or change their minds and who don't fit neatly into either of these dichotomous groups, but whom we also need to understand their outcomes. Okay, so shifting gears just a little bit from a lot of this research in epi, I wanted to talk about how do you put all of this data into practice and how do we provide medical management. So first off, medical management aims to provide patient-centered care, or patient-centered approach to care. And while this statement might sound simple at first blush, what I'm saying is actually a pretty profound shift in the way we practice nephrology. And what I'm talking about is an ideological shift from a disease-based approach to a patient-centered approach to care. So here in a disease-based approach to kidney care, the goals of treatment are intended to affect biological processes like anemia, phosphate levels, blood pressure. And the things that we use to treat these goals are here in the arrows, ACE inhibitors, binders, and things. And testing and diagnostic reports are really central and conditional on the way that we provide care. But in a patient-centered model, the goals of therapy are defined by the patient. And these goals might be longevity, but they could also be staying at home, remaining financially afloat, being pain-free, or legacy. Treatments to support these goals sometimes overlap with those in a disease-based model, like, say, diuretics or ESAs, but sometimes they can be quite different or the opposite, like deprescribing or home care services like hospice. In this approach, the patient is really front and center in guiding how we practice. With medical management, as the kidney disease progresses, there is progressive integration of supportive approaches to manage kidney disease. And I'm sure many of you are familiar with some version of this diagram, and it reflects how when illness is first diagnosed, much of our clinical efforts are focused on interventions to mitigate disease progression. However, as the illness progresses and symptoms compound, with medical management, we increasingly lean on supportive measures to manage the illness. And so what this means, or what it translates to, is more tools in our toolbox to help our patients. And so here I show you a table dividing our interventions between those that are disease modifying and those that are more supportive. So for example, if you have a patient with shortness of breath, you might begin with a disease-based approach to address the symptoms, like starting diuretics to eliminate extra fluid. But as patients become more diuretic resistant, you might incorporate more supportive approaches like using nitrates or narcotics. With pruritus, you might try to lower phosphate levels at first using a disease-based approach, or you may incorporate some more supportive measures like using gabapentin. In some instances, there will not be disease-modifying interventions that we can use to help our patients, like with tremors or myoclonus, and that what we have to offer are supportive approaches. In other instances, like hyperkalemia and acidosis, there really aren't profound day-to-day symptoms, and so disease-based approach makes more sense. Which side of the column you might use more or less of really depends on the patient and what their priorities are. You might have a patient like the one represented in the figure on the top who wants to do everything to hold back disease before trying supportive measures. Or you might have a patient like the one represented in the lower figure who wants to do everything they can to keep living, just not kill themselves trying. Medical management also best serves patients when a whole person approach to care is taken. So a whole person approach acknowledges the fact that health and wellness are not simply determined by a patient's biological characteristics. We are now increasingly recognizing that wellness includes mind, body, soul, and community health. So in the UK, which perhaps has the most developed models of medical management, most of these programs not only do the typical things that we do for patients, like blood work, providing ESAs and IV iron, but they also provide things like social work support, psychological support, home visits. Some even provide occupational therapy. I think where we struggle here in the US is who should be leading medical management? Who should be the quarterback for this care? So in the UK, where there are 71 renal units, most have a dedicated conservative care pathway or medical management pathway. And they work in close partnership with palliative care and hospice services. Now in the US, to the best of my knowledge, there are no dedicated conservative care or medical management programs. And truthfully, I'm not sure whether this is something we should necessarily strive for. I think it's also important to recognize that not everyone in this country believes that nephrologists should be the one providing medical management of advanced kidney disease. So this was a national survey study that asked primary care providers about hypothetical patients who are approaching ESRD and whether or not they would refer these patients to a nephrologist for dialysis. And first off, what I thought was interesting is that on average, primary care providers did not or chose not to refer at least 2 patients a year to a nephrologist, which means that a lot of the work of medical management is actually being done by primary care and not by us. When asked about hypothetical patients, it seems that primary care providers tend not to refer patients with severe cognitive impairment to us around decisions about treatment of their advanced kidney disease. Now, I personally, as a nephrologist, obviously am biased. I feel like we nephrologists have an important role in this and that we have something valuable to offer our patients who don't want to undergo dialysis. So this is a study of a cohort of patients who are enrolled in medical management programs, and they compared survival between those who were managed by a nephrologist leading up to enrollment to a conservative care program and those who were not. And what you can see is that those who received nephrology care prior to enrolling in this medical management program tended to live substantially longer than those who were not managed by a nephrologist. Now, there's a lot of confounding here. Patients who didn't get nephrology care may have been too sick and were progressing too fast to make it into a nephrologist's office. But for me, I think what this study serves as is really food for thought, that perhaps we as nephrologists provide unique skills to the management of advanced kidney disease that you can't quite get out of hospice or primary care. And so to conclude my talk, I wanted to just kind of ruminate a little bit about the challenges and the opportunities to do research in medical management as we try to develop the evidence base to guide future care. So the first big gap in knowledge that you might have gathered from earlier from my talk is that we don't really know what are the best practices for medical management in this country. So not only does most of the data on medical management come from other countries, but the outcomes reported for medical management in these other countries vary substantially. So this is a figure that lines up the reported median survivals for different medically managed cohorts from around the world, starting from a GFR less than 15. And you can see the wide range from a median survival of 4.9 months in Spain to 41 months in Hong Kong. Similarly, when you look at end-of-life care, the practices also vary widely. So here I published. Here are some of the data on published rates of in-hospital death and hospice enrollment for different medically managed cohorts around the world. Here we do have some data from the US from a study that we did in the VA health system. In the US, we kind of are somewhere middle of the road here in terms of performance in end-of-life care. So I think future targets for investigation might be exploring reasons for this variation in outcomes. Are these differences due to underlying differences in the distribution of characteristics in these populations? Is it due to differences in our clinical approaches to medical management? Or are they differences in when decisions to forego dialysis occur? And so I really don't know, and I think this is kind of interesting. I think the other ostensible challenge to growing the evidence base for medical management is that researching medical management is methodologically really difficult. So imagine theoretically, when measuring outcomes, we can imagine the trajectory of a patient like this. They have kidney disease, they're progressing, and then at some point they reach a stage in their illness where we think they're likely going to develop kidney failure. And so we need to start thinking about treatment options. A decision is made, and patients either go down a path of preparing for dialysis or conservative care medical management. At some point down the line, patients who are preparing for dialysis eventually start dialysis, and you keep following them along, and they ultimately pass away. Now, some studies start measuring outcomes or events from a common GFR threshold. The major drawback to this is that there's the issue of lead time bias, which can inflate outcomes such as survival at time at risk for an outcome. So, for example, this was a study done in the National VA Health System that compared 2-year survival of veterans with advanced kidney disease, those who were treated with dialysis and those who were medically managed, regardless if this was an explicit choice not to do dialysis or that the indication for dialysis never arose. And here, survival was stratified by age group as well as different GFR thresholds. And for all age groups, if you measured survival from an earlier point in their disease trajectory, or essentially anywhere above a GFR of 10, survival appears similar between patients treated with dialysis and those who were treated with medical management, suggesting a strong component of lead time bias. Now, alternatively, you could study medical management and start measuring outcomes from a common decision point, which will cut back lead time bias. The issue, and this is technically sometimes possible because those that have dedicated medical management programs, there's often an enrollment process and a consent form that's signed, so it's easy to identify when a decision is made. But I think in most circumstances, treatment preferences evolve and vacillate over time, and it can be really hard to pinpoint just exactly when the decision for medical management actually occurred. The other issue is I think we commonly deal with patients who are simply not ready to make a decision about dialysis or need to get sick first before they cross that proverbial bridge and make that decision. And I don't think that's necessarily a bad thing, given the high competing risk for death in our older and more frail patients. So this was a cohort study done in France that looked at death and the risk of starting dialysis in patients who are at different places in their decision-making at the time of enrollment. All the patients were over the age of 75. All of them had a GFR less than 20, and they were followed for several years. And here patients were grouped according to where they were at in their decision-making. So blue were patients who knew they wanted dialysis. Green were patients who were not ready to make a decision. Orange were patients who had decided they didn't want dialysis, and yellow were patients whom their nephrologist simply withheld dialysis from them. And what's interesting to me is that everyone who said they wanted dialysis pretty much got dialysis, and I don't know if this is like a fait accompli situation or if there was just a strong sense that they were going to reach ESRD. I also think it's interesting that the patients whom their nephrologist withheld dialysis also universally didn't get dialysis, which suggests to me that physicians are really unwavering when it comes to deciding who does and who doesn't get dialysis. And then 40% of patients who said they didn't want dialysis actually ended up getting dialysis. And it's not really clear, did they change their minds? What happened? I'm not really sure. But what interests me most here is that for patients who are not ready to make a decision about dialysis in the green, half of them ended up starting dialysis and half of them ended up dying. Not clear of what cause, ESRD or otherwise, but ended up passing away. And so what it signals to me is that the risk of starting dialysis between those who had made a decision not to do dialysis and those who were just not ready to make a decision were similar. And so outcomes between these groups are who make a proactive decision and those who don't and are reactive are actually quite similar. So going back to research methods, other studies try to research medical management and outcomes by starting measurements at a putative start date. So they identify when dialysis was started and then try and regress a putative start date for when conservative care may or started for those who ended up on a medical management pathway. The problem with this approach is that it excludes patients who were preparing for dialysis but never started. And it can give the appearance that survival on dialysis is longer, or maybe longer than it truly is. It also makes one wonder whether or not these patients should have really been on a pre-dialysis pathway and not a conservative one. The other problem with this is that medical management is not one of those things where you flip a switch and you just kind of start providing it like you can with dialysis. Medical management is usually provided along a continuum of disease. And so what you end up introducing is actually lag time bias. Another consideration when comparing medical management and dialysis is that it's easy to compare groups when there isn't a lot of treatment crossover. And it seems, at least for other developed countries, this is fairly infrequent. Crossover is reported to be anywhere between 0 and 11% between both groups. But in the US, there is this perception, whether true or not, that we are far more fickle people, and plans are always changing. So as Mike Tyson said, everyone has a plan until you get punched in the face. And so another way to measure outcomes of medical management is to do a mortality follow-back study, or take a retrospective view and start from death and what the patient ended up on and looking backwards. The issue with these mortality follow-back approaches is that it best serves understanding the quality of death and dying, but provides limited information, or limited prognostic information, to help us guide care when we're trying to move forward in a treatment plan. So for instance, this is a study that examined where patients were in the 3 months before starting dialysis and the year after starting dialysis. The horizontal line, down the horizontal line represents each line along the horizontal line, vertical line, excuse me, represents a unique patient. Red is time that patients spent in the hospital. Orange was a time they spent in a nursing home, and gray was when they were facility free. The black line represents when patients died. What you can what you can see is that if we had taken a mortality follow-back approach where we looked from death and looking backwards, the impression that we might get is that patients who die within a year of starting dialysis have experience highly intensive patterns of care, and one wonders whether or not dialysis should have been started in these patients. But this mortality follow-back approach would have missed these other groups here, who within the year of starting dialysis were alive but still sick, alive but maintained the same level of health, and those who were alive and started dialysis and actually got better. And so I think an area of future investigation for medical management is trying to develop or find models that can accommodate this evolving treatment preference and shifting realities of life. Okay. So in conclusion, I hope that I've shown you that dialysis is a powerful default and patients face an uphill battle to receive medical management, that survival and quality of life may be similar between patients opting for medical management versus dialysis, at least among certain groups. Medical management is a patient-centered, multidisciplinary, and whole-person approach to advanced kidney disease, and that more research needs to be done to understand care practices and outcomes of medical management, specifically in the U.S. So that's the end of my talk here. And I'm happy to answer any questions.
Thank you so much, Susan. That was an incredible talk. I'm going to open up to questions, and people can, again, sort of chat the message in the Cisco WebEx event panel on the right. I'll start out with a question. I love your slides and your presentation of this idea of a transition from sort of disease-centric, disease-based approach of our interventions and our way of going about a clinic visit to more of a person-centered approach, and one that discerns patient values as primary data that will help guide our interventions. Is my question to you is, in our current system, in a busy CKD clinic, when we are balancing managing anemia and bone mineral disease and all of these other biochemical aspects of illness, do you have any thoughts or insights on how to protect enough time and to get the patient's sort of support system, family members in the room in order to actually talk through and develop a sense of their values to help them in their approach to the decision?
I think several things bubble up for me in that question. The first is that there seems to be this impression that taking a more patient-centered approach requires more time than a disease-based approach, and I don't think that's true, that we feel very comfortable spending lots of time describing hyperkalemia and how it works and what we can do for it and blah blah blah. But we have no qualms in terms of spending a lot of time on that. But somehow there is this perception that if we ask patients about what's important to them, that inevitably takes more time. And I don't know. I don't believe that that's actually true. And I'm curious to see whether or not there are studies that actually compare clinical visits, real-time clinical visits, those that take a patient-centered approach and those that do not. I hear from colleagues in palliative care who do palliative care research is that actually there isn't a significant difference in time. So do want to dispel that misperception. The second is, I think there are many ways in which one can incorporate a patient-centered approach or patient-centered questions, even to these questions that may appear to be medical or disease-based approach questions. So, for example, you have a patient who is anemic, and you're trying to decide whether or not you want to have them do injections of ESAs. You may simply want to pose the question, help me make this decision for you. I have a treatment for your anemia that could potentially improve quality of life and symptoms. It also comes at the burden of doing these injections, sometimes as frequently as a weekly basis. Help me understand what's important to you here. And I think there are ways in which one can readily incorporate this kind of patient-centered framework into their decision making and blend these two approaches.
Thank you so much. That's very helpful, and I love that approach. I love the idea of being able to blend the two. And my personal bias, having trained in palliative care as well, is that it doesn't take as long as one might imagine. Okay, I see a question in from Woody Moss. He says, great presentation. What should we be teaching the nephrology fellows to make medical management considered as an acceptable option for older CKD patients?
That's an interesting question. I think almost underneath or behind that question is the issue of values and personal bias. The data, I think, objectively is quite convincing or makes a compelling argument for medical management, and yet there's still this resistance to offering it or even to practice it and to learn about it. And so I think what we do need to do is dig a little bit deeper and try and understand what are the biases that they are practicing medicine with. And again, how do you put the patient front and center rather than themselves or what might be put out there in the textbooks? I think we can help this cultivating this awareness through our education, not just in terms of explicitly talking about our biases, but needing to point out that the education that we do provide is heavily biased towards dialysis and with very little on medical management itself. I think if there was more parity in education between medical management and dialysis, perhaps people would less likely have that bias in terms of providing medical management. I hope that answers.
Yes, absolutely. Thank you.
And then we have one question from Dr. Dialysis. If you could add or change one thing in a CKD clinic to make medical management a more routine option, what would you do first?
I think it would be maybe piggyback on the last, my response to the last question is really normalizing it. And normalizing it has to come in different ways. One is, again, when you look at the things that we put out in the waiting room for patients to read, it's all on dialysis, maybe even some on transplant, but there's really nothing there on medical management. And so that needs to change. And then the comfort with which providers can talk about it. Right now, medical management is discussed more, it is not discussed at all or discussed as a measure of last resort. And so how can you reframe it as being part of the standard of care, I think would help to make decision making far more informed and balanced and ready available to patients.
Yeah, fantastic. That I agree. And you know, in my training in nephrology, as a group of fellows, our year we did a small quality improvement project where we did exactly that. We actually made sure that information on conservative care was provided during our sort of CKD education classes, which prior to us had been called like dialysis education classes. So using language that normalizes and sort of emphatically, explicitly indicates that there's a choice is there. And then interestingly, in one of the sessions, someone actually raised their hand and said that they had read the New York Times article from last February that said, you know, sometimes people don't even get offered conservative care. So thank you for bringing this up. So there was some patient awareness of this, even just from popular press and public sort of efforts that are increasing awareness, even if it doesn't come directly from medical sources.
Mm-hmm.
There's another question here. So this comes from Elena Popova to all the panelists. As a medical student looking at residency and potentially eventually fellowship programs, are there any specific institutions in the US that you know of that are doing research and trainee teaching on medical management that you would recommend looking into?
Oh gosh, there are, and this is going to be so biased, because obviously here at the University of Washington, we're doing quite a bit on it, and then just within the VA health system, we're doing quite a bit of research. I do want to say that the VA recently put out clinical practice guidelines, updated clinical practice guidelines on CKD management, and now explicitly talk about medical management and offering it, which is a huge leap forward as compared to what you see in our KDOQI guidelines. And so I think, you know, places where there's a VA health system here at the University of Washington, it's also very strong. Other places where I know that there's research is UCSF, and University of Pittsburgh. There, and then Tufts University, I think, are, I guess, and excuse me, and Harvard are probably research, where quite a bit of research is coming out in terms of medical management here in the United States. In terms of clinical practice, there's actually a lot more places than this where there's research being done. Where there's research being done. There are more and more nephrologists like Dr. Gelfand who are training in both palliative care and in nephrology. Just up and down the West Coast that I can think of. In addition to the University of Washington and UCSF, there are folks at University of San Diego. Dr. Coombs is in the University of New Mexico. Denver has some folks. University of Rochester, NYU. And so there are a lot of places that are cropping up I think there is this growing interest in this care pathway. It'll be interesting to see whether or not more and more people are going to actually be making this decision to go to medical management. At least when you look at USRDS reports in terms of the incidence of dialysis in this country, that hasn't changed really in the last 2 decades. It might be going down slightly in the last couple of years, but it's a little too early to tell. At least in terms of practice, there seems to be, we seem to be doing the same thing. Has awareness changed? Definitely. When you look at the articles, and as Dr. Gelfand mentioned, just what articles are even published in the New York Times and things are changing. And so it may be soon that that practice will follow suit to what is kind of growing consciousness in our community.
Great. And I'll add one thing to that as someone who just went through training. I think there are these this is a very exciting time to be in supportive nephrology or in palliative care and nephrology, because there are so many seeds on the East and West Coast for developing this. You also, like Susan was saying, arranging a rotation in the UK or in Australia can be extremely fulfilling as a way to see how a much more robust developed system, albeit a very different health system, has taken to this. And I'll say that, yes, NYU, I think Jennifer Scherer is doing research in a conservative care program there. And then recently at Brigham, a specialized service called Kidney Pal has started trying to meet the palliative needs of kidney patients, and will be doing a conservative clinic in coming time. Great.
And then we have one more question from Kate Siaka. She asked, you mentioned that you do not think that a structured medical management pathway might not be the right thing. Can you say more about that?
Oh gosh, and this is based on some unpublished data, which I hope to get out there soon. But I think it's due to the conceptualization of medical management here in the U.S. Versus other countries. One, and the second is the way that we make decisions in the United States as compared to other countries. For a medical management pathway, I think to actually even exist is that there has to be patients, and a good number of them, who know early on that they don't want dialysis. And there has been at least qualitative data here in the US that suggests that patients just don't know. They're just not sure. And they're not ready to make a decision early in the course of disease when they're asymptomatic. And so do you put them all in the medical management pathway and then they exit to do dialysis, or do they have to sign up for medical management and be in a default pre-dialysis pathway? I don't know. I don't know what would be the best approach. So there's that issue of timing of decision making. The other issue is that and the qualitative work that we've done is that patients don't want to choose between when the choices are presented to them. They want both, and they want to find ways to have both, which then challenges, I think, the way that we think about kidney disease care. The whole notion that we have to make them choose, and this whole idea that we have to make them choose is really to convenience us as providers. It's easy when patients are on a pathway. We know what to do with them. We can automate it. We can make things efficient. But if we wanted to walk with a patient through their illness, and we would flex with them and where their feelings were. And so is really the model of care two separate pathways, or simply tossing this whole notion of pathways out and just moving and walking with the patient, no matter where they go or wherever they feel at any given moment of time? And I think those two are issues, at least continue to come up in my own research, as well as what I see in other people's research about whether or not a distinct medical management pathway could exist in this country.
Wonderful. Okay, well, on behalf of the whole Coalition for Supportive Care of Kidney Patients and Sarah Combs, Thank you so much, Susan, for such a thoughtful talk and for all of your work in this area. I can't wait to see what you do next and really appreciate your time.
Sure, thank you. Thank you everyone for showing up today.
Thanks a lot, everyone.